Welcome to the Deep Dive, the show that cuts through the noise and extracts the most crucial nuggets of knowledge from a stack of sources, giving you, well, the ultimate shortcut to being truly well-informed. Today, we're embarking on a fascinating journey to decode one of the human body's most secret and critical languages, arterial blood gas, or ABG, interpretation. Think of it as unlocking a real-time, highly detailed report card straight from your internal physiology. Our mission today is really to demystify those complex numbers you see on an ABG report, turning them into clear, actionable insights about the body's delicate internal balance. We're going to transform what might seem like, a daunting puzzle into a systematic detective process. Get ready for some genuine aha moments, because understanding ABGs isn't just about memorizing values, it's about seeing the intricate dance of life happening within us.
Absolutely. And it's a dance that has profound implications. ABGs are truly essential because they provide immediate, actionable intelligence on three vital aspects: how well your body is getting oxygen, how effectively it's breathing out waste, like CO2, and whether its internal chemistry is staying balanced. Grasping these numbers is what fundamentally guides medical decisions in critical situations, allowing for precise interventions that can literally mean the difference between life and death.
Okay, let's unpack this then and jump right into why this immediate data matters so much. Imagine a situation where a patient's condition is rapidly changing. You need a live update, a direct line to what's happening at the most fundamental level inside their body. That's precisely what an ABG offers: a real-time snapshot, as you said, of their physiological status. It's not just some delayed lab result you wait hours for. It's information that informs decisions, well, in minutes.
Exactly right. This isn't just theory. Consider this. ABGs measure oxygenation, which is how much oxygen, the BO2, is dissolved in the blood, and also how saturated the hemoglobin is with it, SaO2.
Right.
They assess ventilation, which is how efficiently the lungs are removing carbon dioxide, the PaCO2, the body's primary acid component, essentially. And crucially, they tell us about the acid-base balance, ensuring the blood's pH stays within that incredibly narrow range, vital for, well, all cellular functions. When any of these go awry, the entire system can quickly destabilize, leading to conditions like respiratory failure or metabolic collapse.
Wow, incredibly narrow range. That really is an understatement. Our sources reveal something that's quite striking, almost chilling, really. A blood pH below 6.8 or above 7.8 indicates a life-threatening situation requiring immediate intervention. Just how narrow is that window again? From 7.35 to 7.45 is normal.
That's it.
So that means you've got less than 0.6 pH units of wiggle room before things become critical. What makes that range so crucial, so unforgiving?
It's all about cellular function. Every single enzyme in your body, every protein that facilitates chemical reactions, is highly sensitive to pH. When the pH shifts too far from that optimal 7.4, these enzymes change shape, they stop working efficiently, or sometimes they just stop working entirely. Imagine trying to run complex machinery with the wrong kind of fuel. It simply won't function. At a cellular level, extreme pH disrupts metabolism, protein synthesis, even the electrical activity of your heart and brain. That narrow window isn't just a number. It's the precise chemical environment required for life itself.
That really puts it into perspective.
Yeah, and the quote from our sources sums it up perfectly. ABGs provide a real-time snapshot of a patient's physiological status, enabling timely and informed medical decisions. This isn't just understanding complex chemistry. It's about making immediate informed choices that can, quite literally, save a life. It's the difference between guessing and knowing.
So with such a tight pH window and such severe consequences for even small deviations, it really begs the question, how on earth does the body manage to keep its internal environment so precisely balanced? It sounds like a constant high-stakes juggling act.
It absolutely is. This is the fundamental concept of homeostasis in action, maintaining that pH stability. And for acid-base balance, it primarily comes down to a dynamic duo working constantly behind the scenes.
Yeah.
Your lungs and your kidneys.
Uh-huh.
Think of them as the body's primary pH regulators.
Okay, the dynamic duo.
Exactly. The lungs are the rapid responders. They primarily control carbon dioxide, CO2, which is essentially the body's volatile acid. When you breathe, you're not just taking in oxygen, you're also exhaling CO2.
Right.
If your body has too much acid, your lungs can increase your breathing rate and depth to blow off more CO2, quickly making your blood less acidic. Conversely, if your blood is too alkaline, your breathing might slow down a bit, retaining more CO2, making the blood more acidic. It's a quick, almost instantaneous adjustment.
So lungs are the sprinters.
You could say that, yeah. Then you have the kidneys. They're the long-term, more powerful regulators, the marathon runners, maybe. They primarily manage bicarbonate, or HCO3. Bicarbonate is the key alkaline buffer in the blood. It soaks up excess acid. The kidneys achieve this through a process of reabsorption and excretion. If there's too much acid, the kidneys will ramp up bicarbonate reabsorption, holding on to more of it to neutralize the acid. If there's an excess of base, they'll excrete more bicarbonate. This process is slower, though, taking hours to days to fully kick in, but it's incredibly effective for sustained control. So any significant disturbance in either of these systems, lungs or kidneys, is what leads to the acid-base imbalances that ABGs so accurately help us identify.
That makes perfect sense. Lungs are the quick fix artists, kidneys the meticulous long-term engineers. But okay, before we even get to interpreting these vital numbers, we have to talk about the foundational step, getting an accurate sample. Because let's be honest, even the most brilliant interpretation is useless if the initial data is flawed. It's like a detective trying to solve a case with contaminated evidence, right?
Exactly. You've hit on a crucial point there. The integrity of the sample is absolutely paramount. There are 4 critical steps to ensure accuracy right from the start, and overlooking any one of them can completely skew your results.
Okay, 4 steps. What are they?
First, site selection. An ABG needs arterial blood, not venous, because we need to assess oxygenation and the precise acid-base status coming directly from the lungs. Common sites are the radial artery in the wrist, the brachial in the arm, and the femoral artery in the groin.
And I hear the radial is usually preferred.
Often, yes. It's relatively superficial, easy to access, and crucially, it usually offers collateral circulation via the ulnar artery, which means if there's any issue, heaven forbid, with the radial artery puncture, blood flow to the hand is still maintained via the other artery. Makes it safer.
Got it. Safety first. What's step 2?
Second, syringe preparation. You must use specialized pre-heparinized syringes. Heparin is the anticoagulant that stops the blood clotting in the syringe.
Okay.
But here's a critical detail. You need to avoid excess heparin. Too much heparin can actually dilute the sample, which can falsely lower both the pH and the PaSCO2 readings, leading to incorrect interpretations. It's a delicate balance.
Right. Not too much, not too little. What's third?
Third is air bubble prevention. This is a big one.
Wow.
Any air bubbles trapped in the sample introduce atmospheric oxygen and allow carbon dioxide to escape from the blood into the bubble. This falsely elevates the PO2, making it look like there's more oxygen than there actually is.
Wow.
And it significantly lowers the PaSCO2. You can imagine how misleading these results would be. It could lead to a major misdiagnosis of the patient's oxygenation or ventilation status.
Definitely need to get those bubbles out. And the last step.
And finally, timely transport and analysis. Once collected, blood samples are still metabolically active. The cells continue to consume oxygen and produce CO2. To minimize these changes, samples need to get to the lab fast, usually transported on ice to slow down that cellular metabolism.
Okay, on ice. How quickly?
Ideally, analyze within 15 minutes if kept at room temperature, or you have up to about an hour if it's properly iced. If you don't follow these steps, that real-time snapshot we talked about becomes a blurry, unreliable picture from the past, not the present.
That's incredibly detailed, and it really underscores how much precision is needed even before the numbers are generated. All right, now that we understand the careful groundwork required, let's get into the actual parameters of the crucial data points you'll be decoding. What exactly are we looking for on an ABG report?
Well, the main parameters we assess are pH, PaCO2, HCO3, PaO2, AO2, and base excess. While all are important, the pH, PaCO2, and HCO3 are really the core for that initial acid-base assessment.
The big 3.
Exactly. They guide us in diagnosing whether the primary problem is acidosis, meaning too much acid, or alkalosis, too much base, and whether it's respiratory, so lung-related, or metabolic, kidney, or other related, in origin.
And to give you listening a clear baseline, here are the normal ranges you'll be using as your guide. Think of these as the Goldilocks zone for each measurement. Your pH should be between 7.35 and 7.45. PaCO2, that's the partial pressure of carbon dioxide, is typically 35 to 45 millimeters of mercury, or mMHg.
Right.
PaCO2, the partial pressure of oxygen, is generally 80 to 100 millimilli-H.
Yep.
HCO3, or bicarbonate, is 22 to 26 milliequivalents per liter, MEQL. SiO2, representing arterial oxygen saturation, basically how much oxygen is carried by your red blood cells should be 95 to 100%.
Ideally.
And finally, base excess, which indicates the amount of base in the blood, should be between -2 and +2 MEQL.
Now, what's fascinating here and really important is that while these normal ranges are our essential baseline, we must always consider the patient's unique clinical context alongside these values.
Ah, context is key.
Always. A number that might seem normal in isolation could be very concerning given the patient's overall condition, their medical history, maybe even their altitude. For example, a PaO2 of 85 might be perfectly acceptable, even good for someone with chronic lung disease, but quite alarming for a healthy young person at sea level.
That's a really important caveat. So interpreting ABGs can seem like solving this complex puzzle, especially when you first look at all those numbers together. But the good news is there's a systematic, stepwise approach that simplifies it, minimizes errors, and really makes you feel like that detective sifting through the clues. It's less about intuition and more about method.
Precisely. We break it down into 5 crucial steps that will guide you through the data, making sure you don't miss anything important.
Okay, lay them out for us. Step 1.
Step 1. Assess pH. First things first, determine if the patient is in acidemia, meaning their blood is too acidic, pH less than 7.35.
Okay.
Alkalemia, where their blood is too alkaline, pH greater than 7.45, or if their pH is actually within the normal range. This tells you the primary direction of the problem.
Acidic, alkaline, or normal. Got it. Step 2.
Step 2. Identify the primary disturbance. Once you know the pH direction, look at PaO2, representing the lungs, and HCO3, representing the kidneys or metabolic system. If the pH is acidic and the PaO2 is high, it's likely a respiratory acidosis. If pH is acidic and the HCO3 is low, it's metabolic acidosis.
And the opposite for alkalosis.
Exactly. If the pH is alkaline and PaO2 is low, it's respiratory alkalosis. If pH is alkaline and HCO3 is high, it's metabolic alkalosis. This step identifies the original problem system.
Okay, find the culprit. Step 3.
Step 3. Evaluate compensation. Now I ask, is the body trying to correct the imbalance? If the primary system is out of whack, the other system, lungs or kidneys, will attempt to compensate. We need to determine, is this compensation partial, meaning the pH is still abnormal, but it's moving towards normal? Is it full, meaning the pH is actually back within the normal range, or is there no compensation happening at all yet?
Partial, full, or none. Makes sense. What's step 4?
Step 4. Assess oxygenation. This is where we look closely at the PO2 and SO2. Is there hypoxemia, meaning low oxygen levels in the blood? This helps evaluate lung function beyond just CO2 removal.
Right, the oxygen side of things. And the last step.
And finally, step 5, calculate a ZN gap. Now, this step is only necessary if you've identified metabolic acidosis back in step 2. It's a calculation that basically helps determine the underlying cause of that specific type of acidosis. We can maybe touch on that calculation a bit later if we have time.
Okay, that 5-step framework sounds incredibly helpful. Let's put on our detective hats and try a few examples to see how this stepwise approach works in action. We'll start with a fairly straightforward one. Primary respiratory acidosis. Here are the ABG results. pH is 7.25, PaO2 is 60 mmHg, and HCO3 is 24 MEQL. Take us through it.
All right, let's walk through our steps for this case. First, step 1, assess pH. Our pH is 7.25. Since normal is 7.35 to 7.45, this pH is clearly less than 7.35. So we're dealing with acidemia. The blood is too acidic.
Okay, acidemia.
Now, step 2, identify the primary disturbance. We look at the PaCO2. It's 60 mmHg. Remember, normal is 35-45 mmHg. So 60 is elevated. High CO2 causes an acidic condition. This points directly to a respiratory cause for the acidosis.
Because the CO2 is high.
Exactly. Then we check the HCO3, which is 24 MEQL. This is perfectly within our normal range of 22-26 MEQL. This means there's no significant metabolic contribution or, importantly, compensation from the kidneys to this current pH imbalance.
So the kidneys haven't reacted yet.
Not significantly, no. So based on these 2 steps, our conclusion is that the primary acid-base disturbance is respiratory acidosis. What's fascinating here is how quickly just 2 numbers tell us so much. This pattern could indicate something like hypoventilation, maybe due to an overdose, severe asthma attack, or COPD flare-up, where the lungs just aren't effectively blowing off that CO2.
That's a clear-cut case. It certainly feels much more manageable when you break it down like that. Okay, let's try another one, maybe a little more complex. This time we're looking at respiratory acidosis with partial metabolic compensation. Here are the numbers. pH is 7.3 UO, PaCO2 is 65 mmHg, and HCO3 is 30 LEQL.
Great example. Let's tackle this one step by step. Step 1. Assess pH. The pH is 7.3 euro. It's still acidic, less than 7.35, so we still have acidemia.
Uh-huh.
But notice it's a bit closer to the normal range in our last example, 7.30 versus 7.25. That a slight shift hints that maybe something else is going on.
Okay, still acid, but less so.
Right. Step 2. Identify the primary disturbance. Our PaCO2 is 65 milli-ULG, still significantly elevated, confirming a respiratory cause for the acidosis, no question there. Then we look at the HCO3, it's 30 MEQL. This is elevated, it's outside our normal 22-26 MEQL range.
Ah, so the bicarb is high.
Exactly. An elevated bicarbonate indicates that the metabolic system, the kidneys in this case, is trying to respond. It's retaining more bicarbonate to buffer that excess acid caused by the high CO2.
So the kidneys are trying to help out.
They are. So for step 3, evaluate compensation. Since the pH is still outside the normal range, still acidic at 7.3, but the HCO3 has clearly increased in an attempt to buffer that excess CO2. This tells us the body is actively working to correct the imbalance, but because the pH hasn't returned fully to normal yet, we conclude this is partial compensation.
Partial because the pH isn't normal yet.
Precisely. If we connect this to the bigger picture, we see the body's incredible attempt to self-regulate, even if it hasn't fully succeeded yet. This might be seen in a patient with more chronic respiratory issues, where the kidneys have had some time to respond, but the underlying lung problem persists.
That's a great example of the body's resilience and adaptive mechanisms in action. Okay, for our final scenario, let's really test our skills with this one, because it looks tricky with that pH in the normal range. We're examining metabolic alkalosis with full respiratory compensation. The numbers are pH is 7.42, PaCO2 is 55 mmHg, and HCO3 is 38 MEQL.
You're right, this one is tricky, and it really highlights why simply looking at the pH number isn't enough. You've got to follow all the steps. Okay, let's do it. Step 1. Assess pH. The pH is 7.42. This is actually within the normal range of 7.35, 7.45.
Right, so it looks normal.
It looks normal, but pay close attention.
Yeah.
It's on the alkalotic side of normal. It's higher than the perfect midpoint of 7.40. This strongly suggests that an underlying alkalosis is present, even though the final pH appears normal.
Interesting. So normal isn't always fine.
Not necessarily. Moving to step 2. Identify the primary disturbance. Let's look at the HCO3 first. It's 38 MEQL. This is significantly elevated, way above our 22-26 normal range. An elevated bicarbonate points directly to a metabolic cause for alkalosis.
Okay, high bicarb means metabolic alkalosis.
Correct. Now look at the PaCO2. It's 55 mmHg. This is also elevated. Normally, an elevated PaCO2 would cause acidosis.
Right.
But here, with the pH being normal to slightly alkalotic, this elevated PaCO2 is actually the respiratory system compensating. The lungs are retaining CO2 by breathing perhaps a bit less deeply or frequently to make the blood more acidic, trying to counteract that primary metabolic alkalosis.
Ah, so the high CO2 here isn't the problem. It's the solution, or part of it.
It's the compensatory response, exactly. And for step 3, evaluate compensation. Because the pH is within that normal range, 7.42, even though it's nice to the alkalotic side, this indicates that the respiratory system has successfully achieved full compensation for the underlying metabolic issue.
Full compensation because the pH is back in the normal zone.
That's right. And this raises that important question. How can a normal pH still indicate a problem? It's about understanding the dance between the body's regulatory systems to maintain balance. The body has successfully brought the pH back into the safe zone. But the original problem, the metabolic alkalosis, is still very much there, and the respiratory system is working overtime to keep it in check.
What might cause that kind of picture?
You might see this in cases of, say, prolonged vomiting, where you lose stomach acid, or maybe significant diuretic use causing loss of acids.
That's a truly fascinating example. It really drives home the point about not just looking at numbers in isolation, but understanding the entire physiological story.
Exactly. And just briefly touching on step 5, the anion gap again. As we mentioned, this is key when you have metabolic acidosis, identified in step 2. The anion gap is basically the difference between the main measured positive ions, mostly sodium, and the main measured negative ions, chloride and bicarbonate, in the blood.
Okay.
Normally, there's a small gap, because we don't routinely measure all anions like albumin, phosphate, sulfate. But if there's an excess of other unmeasured anions, like lactate from shock or ketones in diabetic ketoacidosis or certain toxins, those extra negative charges increase the gap. So calculating it helps us narrow down why someone has metabolic acidosis. Is it due to gaining an unmeasured acid, a high anion gap acidosis? Or is it due to losing bicarbonate, a normal anion gap acidosis? It's a critical clue to the underlying cause.
Got it. So that anion gap is like another detective tool specifically for metabolic acidosis cases.
Precisely.
So what does all of this mean for you, our well-informed listener? We've taken quite a deep dive into ABGs, from the absolutely critical sample collection process, which we can't emphasize enough,
Definitely not.
to the methodical step-by-step interpretation. Understanding that systematic approach and always considering the clinical context around the patient are your keys to unlocking this powerful diagnostic tool. It really is about seeing the story behind the numbers.
And remember, practice really does make perfect here. The more you apply this stepwise approach to various clinical scenarios, maybe looking at case studies or even just thinking through possibilities, the more confident and proficient you'll become. And always integrate ABG results with the patient's full clinical picture, their history, their physical exam findings, all their other lab results. It's never just about one set of numbers in isolation. It's about the entire symphony of their physiology playing out.
Absolutely well said. And as we wrap up, here's something to think about. Understanding how our bodies meticulously balance acidity and alkalinity, minute by minute, day in and day out, reveals this incredible, often unseen resilience. What other internal battles might our bodies be winning right now without us even realizing it, performing these intricate ballets of regulation just beneath the surface? If you're keen to continue your learning journey on this fascinating topic, we'd recommend exploring reputable medical textbooks on critical care, pulmonology, or nephrology.
Good resources are there.
You can also dive into peer-reviewed journals like the New England Journal of Medicine or the Lancet, and check out clinical practice guidelines from organizations like the American Thoracic Society. Until next time, keep exploring, keep learning, and keep asking those deep questions.